Good morning, everyone. It is my utmost honor to introduce our keynote speaker, Dr. Suchandrima Banerjee. Dr. Suchandrima did her Bachelor of Engineering in the field of Electrical Engineering from Jadavpur University. Following her bachelor's, she did a short stint in software engineering before she traveled to the US for graduate studies. Dr. Suchandrima completed her PhD in the field of biomedical engineering in 2007 from a joint graduate program between UC Berkeley and UC San Francisco. In 2008, she joined General Electric Healthcare as a research scientist working on MR technology. She collaborated with many esteemed academic and clinical partners around the globe and has co-authored over 150 research publications. Dr. Suchandrima has been a leader in the healthcare industry for over 12 years. In 2018, she assumed the role of Global MR Neurology Manager at General Electric Healthcare, a position in which she owns the Neuro MR portfolio and research and development strategy. With great enthusiasm, we welcome Dr. Suchandrima Banerjee. Over to you, ma'am.
तुझे याद है क्या ये कौन है? सुचंद्रमा.
Ashutosh pronounced it correctly. You can call me Suchi as well. So I'm going to share my screen. Can everyone see my screen okay?
Yes, ma'am, it is visible.
Okay. Thank you so much for the introduction, and thank you to the ICIBLS organizers for inviting me to give the keynote lecture and for organizing such a great conference. Today, I'm going to talk about demystifying the brain. I mean, the brain is an amazing, complex organ, and how we can shed light on that with magnetic resonance imaging. There's a saying that, beauty lies in the inside. And for those of us who are in the field of developing medical imaging technologies, we take pictures of the insides of human bodies to assess the health and wellness. The mission of our team of scientists is to explore, define, and develop imaging technologies that will improve patient experience, enable neuroimaging research advances, and improved neurocare pathways. I just want to begin by talking about a few global disease facts about the neurological disorders, globally that are on some of the topmost causes for socioeconomic and medical burden. Annually, 15 million people worldwide suffer a stroke, resulting in 5 million deaths and 5 million permanently disabled. And while MRI is not really a player in the acute phase of stroke, where people often get a CT, it's becoming increasingly important in the rehabilitation phase to see how the brain is recovering from a stroke, and also to find out if one is within that urgent critical window of reperfusion, say in an ischemic stroke. Around 50 million people have dementia, with nearly 10 million new cases every year. 60 to 70% of the cases are attributed to Alzheimer's disease. And as the percentage of aging population in the world increases, this is just going to increase as a socio-economic and health issue. More than 264 million people suffer from depression, and that really has many ramifications in the day-to-day life of the person who's suffering and people around them. And in 2013, based on these facts, the WHO, the World Health Organization, said that it really warrants a spotlight on the brain to understand the the chemical, biological, and other factors that really affect the neurocircuits and affect the behavior and the wellness of the brain. And in recent years, there has been a lot of studies. Some of these are government initiatives, some of these are government and industry joint partnerships to look at the different aspects of the brain, pooling in not just imaging data, but also the genomics and the looking at some of the behavioral patterns and lifestyles. And for example, how does education play a role in neurodegenerative diseases? And in 2013, the White House at the time in the United States, the Obama administration launched the BRAIN Initiative, which allocated a large amount of funding through the National Institute of Health to look at various different technology development that would improve in the understanding of the brain and also develop other technologies that can help monitor brain health. Biobank is another large-scale study that started in Europe, in the European Union, and that had a slightly different approach. It does a huge demographic study where just by the sheer number, they keep imaging a large population so that at the end of 10 years, 15 years, you get the statistical power in the different diseases, from cardiovascular disease to dementia to depression and so on and so forth. Around 2012, GE Healthcare, we had a joint initiative with the National Football League to better understand the effects of concussion. That's a big, in American football, there's a lot of head injury, and there has been a wide prevalence of, long-standing issues that happen afterwards, and CTE, attrition of the brain tissue, and depression in many cases. And so we did a large study with many academic collaborators to do to pull in like the clinical data, which was the symptom scores right at the onset of the concussion, after 3 days, after a month, after 3 months, and to correlate with symptom scores the other data from like the path lab test and the imaging from MRI, that they were all pulled together to get a better understanding of concussion. The Human Connectome project, now Connectome has its name coined, in the same way as like genome and other things. This basically means mapping all the brain circuits so that you have an atlas, so to speak, of the brain wiring, which then helps one understand how these circuits and these connections change with disease. Another interesting study that is going on is the adolescent brain cognitive development study. This again is a large multi-site study, the largest of its kind, that's monitoring brain development in adolescents from 9 years of age to 19 years. Again, this can be quite significant in understanding brain maturation, especially because a lot of the psychiatric diseases start right at the adolescent, at the onset of adolescence, and it's most commonly appears like around 18 years of age. There's also the China Brain Project. There are government initiatives in Turkey and in a lot of other places. In Australia, where there is really a lot of emphasis to develop technologies to understand the brain better and to help later in precision diagnosis and development of better targeted drugs as well. So I guess that this is a little bit off topic for this conference, because this is talking about imaging technology in a biotechnology conference. So I just provided a very brief history of neuroimaging. Most of you are probably very familiar with this already. In my mind, the whole journey of medical imaging and neuroimaging started in 1895 when Röntgen discovered X-ray. And then it started being used clinically, say, in the early 20th century. And many of you have probably got an X-ray in your life from an arm fracture, or when someone fell off the bicycle. And it's amazing how this really started this new chapter of imaging the insides of the body. Since then, there has been, through the 20th century, steady progress in medical imaging technology. 1927, the first cerebral arteriogram was done. 1950, the X-ray tomography. So tomography is a way of rotating the X-ray tube so that you just don't get a projection, but you are taking the projection at many different angles, which helps one reconstruct a slice, a section of the human brain or whatever anatomy that is being imaged. In the early 1970s, this is when really the computers came into play, and imaging that has much more computational load came into being. And so the computerized tomography, instead of having an X-ray tube that is rotating, this has a ring of tubes, so to speak, which are all taking tomographic slices or projections at different angles to reconstruct that slice, and also a 3D volume. In the early 1980s, nuclear medicine came into the foray. So instead of an electron, in this case, a positron of a kind of radioligand, like, for example, fluorine-18 or oxygen-15 is injected into the body. PET still remains very popular, and now it is also done in conjunction with other techniques like CT or MRI. So concurrently with these developments, in the early 1980s or in late 1970s, magnetic resonance imaging came into being as well. Here you see all the images, and I think one thing that kind of leaps off right off the bat is you see a lot of more structural detail in an MRI image than you see in a CT or in an X-ray. And in early 1990s, functional magnetic resonance imaging, which is a way of capturing the brain activity, the brain functions, one's cognition, was a field that started during that time. It still remains relatively new, but is an incredibly exciting technology. So one of the things that really sets MRI apart compared to the other technologies is this non-ionizing radiation. So for example, in pediatrics, if one could, it would be, MRI would be a much preferred modality, imaging modality, than a CT. And the contrast here is endogenous. What I mean by that is there are no radio tracers or electrons being transmitted into the human subject. All of this contrast is generated from the protons inside the body. Now, as you know, I mean, most of the body, just like the Earth, is made of water molecules. And the protons in the water molecules preferentially align with a magnetic field when a radio frequency energy is deposited. That's what you see here, that when the body is lying inside a magnetic field, there is a slight increased population that aligns with the field than against the field. And this delta magnetization, net magnetization, is what's behind the MR signal. So that's what gives the MR signal. These are the essential components of an MRI scanner. B0 shows the magnetic field. This magnetic field, generally, this is a magnet that is, superconducting magnet with a permanent magnetic field. There is also an RF coil inside the magnet. So that's what deposits the radio frequency energy. And because it's radio frequency, that's why it's non-ionizing, much longer wavelength than, say, electrons. And then there is the gradient coil, which imposes a DC electrical field, which manipulates the spins of the protons to spatially encode them, so that when we read the signal, we know which part it is coming from. We can also manipulate the contrast we can get from these protons. So 1977, this was the first MR body scan of a human subject. Then in 1983, this was the first brain MRI that was done on a GE 1.5 Tesla. That was at the time the highest magnetic field. And a brain exam, very preliminary brain exam, took about an hour. And with all the technological advances, we have come really a long way. And this is, fast forward to today, when we can get brain images of 100 micron resolution, so each pixel being 100 microns or 0.1 millimeter, we can get that in a matter of minutes. These are images of 7 Tesla that were taken at one of our collaborator sites. You can see here the cortical folds, the perivascular spaces, the incredible detail in the hippocampus, which is responsible for like the short-term memory formation. And here again, you see some like the small vessels, the blood vessels here, the perivascular spaces. I mean, incredible detail that we are getting today from an in vivo scan, which previously was only possible from, say, an autopsy or an in vitro scan. So just to give an example of a brain MRI, why it can give so much more detail. So in an X-ray or a CT image, most of the contrast is, whether it's bone or not bone. You can see some blood. This is for a concussion, again, for the traumatic brain injury, where if one is feeling dizzy or lost consciousness, one would probably first get a CT. And you can see that there isn't much you can see in this image. And 90% of the CT in suspected mild traumatic brain injury are negative for structural injury. But when looking at MRI, once again, you can really manipulate the contrast when the way the images are acquired. So one can look at possible lesions, and here you're looking at like microhemorrhages. But even then, this is an example for a subject who came for scanning right after the concussion, after the head injury happened, a month after, and 3 months after. And these are the structural MRI images taken at these 3 time points. Now, the subject during this whole time was not recovering. I mean, he had symptoms throughout this period, but we don't see much change in the structural image. And that is why, that's where the versatility of MR comes in, and we go beyond structural imaging in imaging the connectivity, the structural connectivity of the neuro-circuits, looking at the level of even axonal swelling to get some information of, whether there's neuroinflammation, has there been axonal injury, to get some correlation with how the subject is feeling over time. This is another example just to show in a pediatric case, as an infant, in a neonate, the brain is mostly water. And then as the brain formation, brain development keeps happening, you can see that the tracts are well formed and you see much more structures in the brain. And here I'm showing in an example that just by tuning some of the parameters during the scan, you can get very different appearance of the brain depending on what you want to see. It's kind of like the many different tools that you have on your iPhone now, or all these apps. I don't know, many of the younger people in the audience probably knows them more, like Snapseed or something, where you get a tonal blur versus a different kind of moody contrast. So you can think of it as something like that, like the different knobs you can dial to manipulate the contrast. COVID-19, that's uppermost in everybody's mind. And Dr. Roy mentioned about the cytokine storm in the previous talk. This is a case, again, I just wanted to show the area of contrast, image contrast that you can get. This was a case that was reported in the Journal of American Medicine around middle of August, in a case where the subject was feeling confused and dizzy, came to Henry Ford Hospital in Detroit. it was a case of, hemorrhages, blood-brain barrier breakage, and cytokine storm, which is quite rare in any of the influenza kind of diseases. But by having such a different range of contrast, it is possible to look at many different aspects or neurological implications of COVID. And right now there have multiple studies, multi-site studies have started. It's like there's something called a pan-COVID study that is looking at the long-term neurological effects of COVID-19. Just to give you an idea of the different techniques that are used, anatomical imaging that, as I mentioned, just captures or acquires the brain structure. And this can be used to measure like the different volumes of the different parts of the brain, like, for example, in temporal lobe epilepsy, to see if there is an asymmetry in the right and left lobes. Looking at cortical thickness, that whether that is thinning, and that's also an indication of degeneration. So a lot of these measurements are derived from these images. Structural connectivity, I'm going to talk a little bit more about this, but you can think of that as the structural connectivities, like the wiring that's inside the brain or the brain circuits. And functional connectivity refers to regions that light up or fire together or get activated together to do a task. And there's a saying that neurons that wire together fire together, but that's not always the case. Then there are ways to image the brain perfusion, cerebral blood flow maps. If there is a slow flow that's coming into a region versus the normal flowing blood, and a lot of these can be important in a stroke to look at slow collateral flows. Also in dementia, as the blood flow slows down, a lot of these can give indications of different diseases. Vascular, again, for cardiovascular disease, to look at like occlusion within a blood vessel, if there is blockage, also if there are plaques in the blood vessels, that can be a risk factor, and so on. And then in the metabolic, looking at spectroscopy, say in a brain tumor, to look at if there's parts of the tumor that are necrotic versus looking at the choline to NAA ratio, to get an idea of the energetics of the tumor without having to do a biopsy. So diffusion MRI, I mean, I talked about this in terms of the like imaging the brain circuits. What is that actually? So diffusion MRI is just based on measuring the random Brownian motion of water molecules within a voxel of tissue. And simply put, higher diffusivity in a voxel means lower signal in the diffusion weighted image. Just like in many of your cellular experiments, you tag a cell. In this case, we apply those DC fields with the gradient coil to label the moving water molecules. So after a period of time, depending on how fast or slow these water molecules are diffusing, we have differences in signal. Diffusion tensor imaging goes a step beyond, where they take multiple measurements which can provide an indication of the directionality of the water diffusion in a voxel. So why do we care? Well, this can be important for many different things. In the case of stroke, as I'm showing here, the diffusion here shows, there is restricted diffusion in this area, which shows that there has been tissue injury, and the cerebral blood flow map from the perfusion also shows that there is a lack of perfusion in that region. All of this is used to make the treatment decision, whether it's too late to do a reperfusion, whether that's the right step going or treatment for the subject. Similarly, for brain tumors, it can give an indication of how dense, of the cellularity of the tumor. And this is the diffusion tensor imaging, which I talked about. When if you take more measurements, you can get the directionality of the water diffusion in that voxel. And these are generally color coded. So you can see that reddish means the directionality is right to left, greenish is anterior to posterior, and bluish means these are superior to inferior. And these are like the white matter bundles or the tracts that are connecting the different regions of the brain. The other technique I just want to talk about is the functional MRI. I mean, that's again, has been used to look at many interesting effects in cognition. The MR signal is not directly sensitive to the neuronal activity, but it is indirectly sensitive to brain activity by the change in blood flow. You know, if there is an area where the neurons are firing, they need more oxygen, and there's more blood flow in that region. And with that, we get this bold signal, which we called blood oxygen level dependent. This is what we get in terms of like a peak that is measured in the MR signal. And that shows up in the MR image as like lighting up of certain regions of the brain. So after that overview, let me just talk about the multiscale neuroscience research. And most of you probably know much more about this than me. I'm just an engineer. But just to give an idea of the complexity of the central nervous system, the population of the world is 7.8 billion, and the number of neurons in the human brain is 86 billion. It's an amazingly complex system, and that's just the neurons. There's also all the support cells for the neuroglial cells, which have their own kind of mechanism for providing nourishment to the axons and also in the cleanup and so on. And some of the reasons why we care to image these things are, you know, myelin can be strongly correlated to development disorders, to like Asperger's syndrome, to autism. And in the other sphere of life, in demyelinating disease like multiple sclerosis, in neurodegeneration, and also to monitor if there is remyelination in response to therapy. The other thing that has been seen is that axons with different diameters are implicated differently in different diseases. And what I mean by that is in some diseases, axons with larger diameters are preferentially lost compared to the smaller diameters. And this is a typical neuron. All the transmission of the electric impulses happen in the synapse between the axonal terminals of the two neurons, and the diameter of the axons are typically a few hundred microns. And the myelin is what's conducting the electrical impulse quickly. So myelin has increasingly been looked at as an indicator for brain development. And there have been all these post-processing image analysis companies that are using MR images to do a map of myelin. And this is being done with age-matched controls as an indicator of brain development. So just to summarize the multi-scale part of it, you know, on the spatial scale, we start with, of course, you know, the symptoms, the clinical symptoms, the behavior, to the white matter tracts that are quite well known, and they connect the different regions of the brain. Then we have the cortical fibers, which are much smaller and much harder to map. And the cortical fiber patterns can also provide some interesting indications in diseases such as cortical focal dysplasia. And there's more and more improvement in imaging hardware, imaging applications with artificial intelligence to move to the level of neuronal imaging. And then if you look at the temporal scale, on the one hand, we image or we monitor changes in brain development over long periods of time, over range of years, or similarly with brain development. But then on the other hand, we are trying to measure or capture brain dynamics that are happening in the millisecond scale. And that's kind of the complexity of multiscale neuroscience research, of spanning this whole spatiotemporal range of scales. I want to give you a couple of examples of how this is done, but from the previous discussion, I think it is amply clear to image something with this resolution and to map these many circuits and to map them to a network requires a lot of horsepower in terms of computing. And that's why this is the time that seems ripe for doing these advancements. New directions in science are launched by new tools much more often than by new concepts. I think everybody envisioned doing this before, but now it's possible with all the computational biology that has happened in genetics, all the work that has happened in control theory with the human cognitive interface, the compute power. I mean, the cell phone that we have in our back pocket now is so much more powerful than the computer that sent man to moon in the 1960s. Data science, how to tease out the data from this enormous amount of big data that is being generated. Just to give you an example, now one MR exam, the data size from that can be about 30 gigabytes. This is just to give you an example of what data explosion that's happening. And of course, artificial intelligence to guide us with all of these really complicated inferencing from this big data. So all of this has come together to enable imaging for neuroscience research, and we are seeing extremely interesting applications of this. These are just some examples of collaborators who work with us. This is an example of the differences in connectome. So again, the connectivity map that is being observed with changes in lifestyle, like with meditation practice, with socializing, and whether they can see differences in the connectome between a depressed and a normal adolescent. This is an amazing study in translational psychiatry from the University of Sydney, showing in like hundreds of micron resolution, the hippocampal connectome, which is really important in many of the neurodegenerative diseases where memory formation is implicated. This is again another study observing and the connectome differences for epilepsy patients versus controls. Now, now there is an increasing practice, I know, in like NIMHANS and AIMS, in a small cohort of subjects in, say, in psychiatric disorder, but also in movement disorders, where the subjects are not responding to drugs, to therapy. And in those cases, they do look at circuit interventions with things with like deep brain stimulation electrodes and also some high frequency ablation. And there we are talking of like micron level precision. The leads of the deep brain electrode that will be planted here needs to touch upon the right tracts to provide the right effect. I mean, a few 1 millimeter difference, and this is a fact, can provide a difference between someone being driven to like the fits of depression to driving at like reckless speed on the freeway. So that's the amount of precision that's needed. And instead of doing this with just an atlas of the tracts, by having this tool to actually map the connectivity tracts in that particular person and to have a personalized treatment plan can be incredibly powerful. This is showing one example. in, again, a human connectome project where they did many different tasks to understand in the depressed emotional state how one reacts differently to different stimulus. They also looked at resting state, which means when the brain is at rest, there is a resting state network or a default mode network. They looked at changes in that as well. And then it is being mapped to the same atlas to show the differences in the response between healthy young adult and the depressed emotional state. A few years ago, there was this really interesting study that happened in University of California, Berkeley, in their vision lab and the neuroscience lab. They collaborated together, where they tried to reconstruct a movie that a person was seeing based on the functional MRI signal. I'll try to play this. Let me see if it'll show up. Are you seeing the screen?
My name is Jack Gallant. I'm a professor of psychology and neuroscience.
Are you able to see the screen, or are you just seeing my slide?
Ma'am, only your slide is visible. We are not able to see the video.
Okay, let me try sharing the video. Thanks. I think when I'm doing that, it is asking like who can share. Okay, now I can. Sorry about that.
Here at UC Berkeley, and my lab works on vision. That's our main focus is on the visual system, and vision's a really important thing to work on because humans are very visual animals, and when humans have damage to their visual system, they're really incapacitated. And natural vision is a lot like watching a movie. So essentially, we were trying to build a model that describes how your brain responds to movies. So if the external world is a certain kind of movie, we want to be able to build a dictionary that will allow us to accurately predict what the brain activity would be that would be evoked by that movie. And then given some brain activity, we want to be able to reconstruct the movie that you saw. So on the left here we have a movie that we showed a subject in the magnet, and on the right we have a brain. And you can see the brain activity is painted here on the side of the brain, but the brain's kind of crunched up in the skull, so it's hard to visualize. So we kind of inflate it and then we flatten it out, and we can see a flat map of the visual cortex and the rest of the brain as the person watches the movie. The problem here for us is to translate between these movies that occur and this pattern of brain activity that occurs. And in the study we talked about in our paper, we just modeled this very back part of the brain, the early visual system, primary visual cortex. And that part of the brain responds to the little local features in the movie, little edges and colors and pieces of motion and texture. But this part of the brain doesn't know anything about what the objects are in the movie. First, we put people in the magnet for several hours, and we show them movies, and we build a model of their brain. And then in the second part, we put them back in the magnet, we show them new movies, and we measure their brain activity, and we decode their brain activity in order to reconstruct the movie. So on the left here is the movie we actually showed people, and on the right is our reconstruction. When the movie that we showed has a fairly common object like a person, our reconstructions are actually fairly accurate. But when the movie that we showed is something rarer, as you'll see in a second, like this abstract thing, then our reconstructions are coarser. Not really so much over here, I guess. I think you'll be able to use this kind of technology for communicating with people who can't communicate, like locked-in patients or people with neurological diseases. I think you could maybe use this in some forms of psychotherapy or dream analysis. I think there's a lot of potential clinical applications for this. When this model worked, we were very happy because it was really quite surprising that it would work at all. We're only taking snapshots of the brain every 1 or 2 seconds, and our reconstructions of movies happen at the movie rate. So that's much faster, and there's no reason one would think that this would work, and in fact, most of our colleagues just told us this would never work. So it was pretty surprising and satisfying when it actually worked.
Okay, I'll just go back to sharing my screen again for the PowerPoint to finish the talk. Can you help me share the screen again? I think it's not letting me. Do you know, I'm not able to share the screen again. Let's see. Okay, now I can. Okay, I'll be quick. I think I'm running long. So I just wanted to touch upon at the end, this is MRI is such a incredibly powerful tool, but only 90% of the world, only 10% of the world has access to MR. And this is a very detailed study by Sairam Gitanath of Dayanand Sagar and Tommy Vaughan of Columbia University, where they looked at the different factors that contribute to access or lack of access of MRI. We need to be portable, compact, lightweight. One needs to have like very simplified, streamlined workflows and so on. Low helium requirement for the magnet, low power, and perhaps where it can be just plugged into a socket rather than always needing to have continuous power, and also to have a sighting in a small room. Right now, we need a room that's magnetically shielded. It has to be reinforced with steel or concrete, so it's quite a big affair to have an MRI scanner sited in a place. And a lot of technology improvement is happening in this area. Last year, there's a small company called Hyperfine. They launched a portable MRI, which they wheel from one room to another. This is a point of care head MRI. And actually during the COVID, and now with the COVID pandemic, they have demonstrated how they're just wheeling this to an emergency center and doing a head scan. The other thing, of course, is to have the scans as fast as possible, so the in and out for the subjects. This is an example of a 1-minute scan, done in the emergency department. You can see that the subject is totally moving this entire time, but one can still get a lot of information within that 1 minute. And then, of course, to have artificial intelligence-based methods for quality control, if the subject is moving or there are other artifacts, to alert the technologist about that and have an image quality dashboard. All of that we feel will make MRI more fail-proof and will reduce the burden of technologist training. The other big need is, even if one is able to get a scan, how to get the scan read, how to get a report of that. And we know of places where there's an incredibly long wait to just get the report back after doing a scan. And to have AI-assisted diagnosis and some automated reporting so that the subject can get some preliminary information after the first scan would help in that respect. And here I'm just showing a mock-up in case of psychiatric disorders. So with that, I want to end saying that with cutting-edge technology, collective innovation through close collaborations and focus on the right problems, the possibilities are infinite. I want to thank all of you for this opportunity, and I would be happy to answer any questions.
Thank you, ma'am. Ma'am, we have a couple of questions from our attendees.
Sure.
Ma'am, first question is, can neuroplasticity cause disease like dementia?
I think it goes both ways. Neuroplasticity can also help reduce the course of dementia. There have been studies where people who were suffering from Alzheimer's disease got trained on video games, to do like vehicular control. There were others who were taught a new language, and new connections were formed, showing that how amazingly plastic the brain is. And then, like you said, on the other hand, neuroplasticity, if certain behaviors can cause some connections to die out, that can contribute to diseases as well.
Okay. The next question is, how does calcium levels of brains affect memory?
Yeah, that's a good question. I'm not a clinician or in the biofield, so I don't want to hazard wrong guesses. Like the sodium potassium pumps play a big role in the homeostasis of the brain. Calcium levels probably have some effect too. I'm not sure about it.
Ma'am, next question is, what's an arteriogram?
Oh, it's the image of the blood flow in the arteries. So you can have one for the veins and one for the arteries.
Ma'am, next question is, can increased frequency of demyelination be monitored through MRI?
That's the hope, being able to monitor at very regular intervals to see if the myelination rate is changing, say, as a response to therapy. Okay. And there are several studies that are looking at that.
Okay. And next question is there any influence of nanotechnology-based materials in imaging field?
Yes. A lot of the nanotechnology is already embedded, for example, in the coils that are used to receive the signal. So basically, you saw the image of this coil around the head that receives the MR signal. In making those less clunky, in the big connectors of that, there's already a lot of nanotechnology involved in those things.
Okay, ma'am, have you really come across any change in brain patterns upon doing meditation, yoga, or any other brain stimulating exercises?
There have been studies that have reported that, where the network, the connectivity changes with meditation. I mean, these things are now very popular. You will see New York Times articles on these, and there have been publications on these showing that there is increase. That's all I can say.
And next question is, how can MR be utilized in studying depression and mania?
Yes, so that's a really active field. On the one hand, to know like the differential diagnosis in depression, there is a lot of work that is going on there, again, looking at the connectivity maps to see if there is a pattern, and also to predict how someone who is suffering depression will respond to a particular treatment. And that seems to be a really big pain point, because right now a patient has to suffer for 3 months before the doctor can decide whether that's an effective treatment or they can change the course of treatment. And by having a way to predict that and to say predict if someone is going to have mild depressive disorder is very important. And MRI it's an active field of research for that.
Okay. Hope we answered all your questions. Thank you, ma'am, for sharing your knowledge with us and taking time out of your very busy schedule.
I have a question.
Yes, ma'am.
Even I have a question to Suchandrima.
It was a
Dr.
really nice
Suchandrima.
talk, Suchandrima.
Asmita, you can go ahead.
It was a really nice talk, Suchandrima.
Thank you.
And I have a question that, your technique seems very promising. So what I'm asking is, like, how early in case of neurodegenerative diseases can you diagnose? Because, that is going to be really useful.
Right. So now the formula is with PET MRI, if you have amyloid positive and the hippocampal volume is less than a standard, then that's the marker for Alzheimer's disease. But then there's also the tauopathy for, the tau neurofibrillar tangles, which seem to correlate more with the cognition changes. And there was the Alzheimer's and dementia study called ADNI, which had this huge database for MRI protocols. In general, diffusion imaging seems quite promising in that. People are also looking at ways to tease out dementia versus vascular dementia. I would say that in these fields, there's still more work to be done because the subtypes of Alzheimer's is what needs to be, differentiated with these techniques. Thank you.
Suchandrima, Dr. Suchandrima, I have a question. Like in the patients who suffer from depression, your talk was extremely wonderful. Who suffer from depression, and let's say the depression is mostly genetic in many of the patients, if it's not induced by stress or any other situation. Do we have any changes in the brains of those patients, like in genetic depressive patients, that is not present in other people? And what kind of signals do they induce, are induced in the brain so that they, they go under massive or severe, they have severe depressive episodes?
So people have seen that certain connections are more compromised than others. That signal that this is going to be a much more severe depression than in other cases. But like you said, genetics plays a big role, and so AI needs to be able to have. We need to have a framework in AI which combines all of these together to provide the proper prognosis of the severe depressive disorders. Because right now it's all population based, rather than individual. Like you take a big population of severe versus the mild, and you can get population difference, but how to get that in the individual, I think that's where you need to combine the imaging marker and the genetic markers.
Okay. Thank you so much.
Thank you.
I had a question as well, Dr. Banerjee. It's a little unorthodox because I'm always, first of all, extremely fascinating talk. And I'm always looking for, you mentioned something about point of care, particularly in the COVID situation. I'm always intrigued by, such attempts. So I was just wondering whether, I mean, this could be totally sci-fi, but whether it's possible to have an unorthodox AI structure developed, which can provide data limited versus big data, and having application rich solution, particularly in point of care situations, for screening or preemptive purposes. So somewhere down the line, if it's at all possible, if a detailed big data oriented MRI image could be deconvoluted into, let's say, billions of information capsules like colors, pixels, geometry, volume, and would it be possible to superimpose onto simpler images like white light snapshots? You mentioned cell phone camera, cell phone computers which could be used as a camera. Is it possible to superimpose such data, create composite images, and that could train AI algorithms to provide the detail of an MRI without having to rely on big data? Is it too fictional?
No, I mean, the concepts are already in use, using the different patches, the edges, the texture in a network, even to identify images and trains a network to give a better quality image reconstruction. In terms of size reduction and dimensionality reduction, there is a lot of work on that. For example, this hyperfine, the portable MRI that I talked about, it uses one receiver channel to receive the data, which already reduces the data a lot. Similarly, in India, the one branch of our company, they have a big initiative in accessible MRI. They're called Gauss line. They're starting some of these like minimum viable MRI where they would receive it with one channel with very little data. And what you just suggested is also very interesting, like an MR fusion of all the data overlaid together, which shows the relevant pathology information. I think that is a really great idea, and there are some work that's being done to have an AI-based report that fuses all the information and the pathology information into just one image that can be transmitted over a spotty network.
It's fascinating. Thank you.
Thank you. Thank you so much.
Thank you, ma'am, once again for sharing your knowledge with us. We will have a 5-minute break now, followed by a lecture by Professor Varsha Gupta. Thank you.
While we are waiting, can we take some more questions, like, to either of the two speakers who have already spoken? So I want to initiate that questions. So I had one question to Monidipa. Since you're here, I guess I might as well go ahead. In your context of modulating the immune system, have you looked at TLR as a target?